Thank you for the introduction. So morbidity and mortality for ALPPS is still considerable, and therefore risk assessment is essential in ALPPS, both preoperatively and between the stages in order to decide to proceed to the second stage of ALPPS. And recently, relatively recently, a futile ALPPS risk score was generated, a risk score to predict mortality in ALPPS patients, and they included all tumor types from centers with at least 5 cases. But it's a risk score that includes all types of patients, including biliary tumors, and we know that mortality in ALPPS for perihyalocholangiocarcinoma approaches 48%. So the risk score was generated using a lot of mortality events from biliary tumors. And the colorectal patients are also included, but have relatively good outcomes. So the risk score is dominated by the events in biliary cases, and almost all colorectal liver metastases patients score as a low risk, and the risk score is not really applicable for this type of patient. So we aim to generate a risk score to predict mortality in only colorectal liver metastases patients. And this is the univariable analysis for the over 450 cases. There were 35 mortalities, which accounts for 7% mortality. And what's very interesting, in my opinion, is what we saw was the baseline volume parameters. So volume a patient starts before ALPPS is really predictive of mortality. But all the interstage volume parameters, so the increase in liver volume after the first stage or the liver volume before stage 2 is not predictive of outcomes. So, of course, the baseline volume parameters were included in the risk score, and below you see that center volume has a great impact on outcomes, but also case experience, because in high volume centers, the first cases have inferior outcomes compared to the later cases, and age, bilirubin, and stage 1 morbidity was also included. And we generate risk score to predict mortality before stage 1 and a risk score to predict interstage using interstage parameters. And above you can see in the stage 1 risk score, age, baseline, FLR to body weight ratio, and total center volume was included in the risk score. And as you can see in the graph on the right, based on the points, you can adequately stratify these colorectal liver metastases patients in different risk groups. Below, you see again in the stage 2 risk score, none of the interstage variables were included, only age, FLR to body weight ratio at baseline, bilirubin 5 days after stage 1, and stage 1 morbidity was in the risk score. And as you can see, the risk score performed well and was well calibrated. So ALPPS is associated with a higher mortality in older patients, patients with small liver remnants at baseline, cases in inexperienced centers, and cases that experience morbidity after stage 1. And none of the interstage volume parameters were predictive of outcomes, which of course, in our opinion, warrants implementation of liver function testing in ALPPS in order to guide the treatment and proceeding to the second stage. And these data question the relevance of the rapid liver volume increase in ALPPS altogether. And if you had, that's the biggest main plus of ALPPS that is usually mentioned, so perhaps we should re-question the relevance of ALPPS based on these data. Thank you for the attention.
The paper is open for discussion, please. So indeed, very interesting and useful and easy to use tool. I think it's you should do an app to build up an app to use it in the clinical practice. So no questions. Thank you very much. We'll move on.